So this is a topic that's quite different from what we've learned and heard about today, but is very important in the canon of what skill sets you need as a vascular surgeon. And basically, we'll start off with disclosures. I have none. I'm not bought and paid for, but I will tell you this, that I'm trained by the guy in the middle, Dr. Robert Harbaugh, who's done close to 3,000 endarterectomies in his career. And so there is that bias that I have personally. And those are the other two Harbaughs, obviously. So the plan of this talk is going to be pretty simple, 5 phases. When to treat carotid artery disease, measurements specifically that you should know, and how the studies are designed based around those measurements, and the differences between carotid artery stenting and carotid endarterectomy. Some technical nuances for people to keep in their mind, back of their minds when they're operating, and some surgical videos which I hope will work at the end of the case. So to treat or not to treat, that is the major question, and I'll go through some of the seminal landmark papers, but I'm going to try to make it really simple because there's a lot of information in each of these papers and it can be interpreted different ways. But we're talking about asymptomatic carotid artery disease, where a patient does not have any prior symptoms and they've just discovered to have carotid artery stenosis. There was a couple of landmark trials, 2 that I'm going to mention in particular. The ACST trial, which finished in 1995. A lot of these trials collected the data actually in the late 80s, early 90s before they were published. And that was during the time where there's a huge popularity in doing carotid endarterectomies around the country. Vascular surgeons in particular were doing a lot of these procedures. This study was designed to collect a large number of patients. It had the typical features of randomized control study, and the primary endpoint was basically ipsilateral stroke or death, essentially in the ipsilateral side of the same side as the carotid stenosis. What's interesting is that they published their relative risk reduction with the use of carotid endarterectomy in asymptomatic patients is 47%. And that's what came in through the press. That's what made it to the headlines. But when actually you dig into the numbers, they didn't publish it, didn't mention it, but the absolute risk reduction was only 6%. And they didn't report this number either, but if you actually calculate the number needed to treat based on just using a 2x2 table, that's 17 patients. So when you talk to patients and counseling them, and you're thinking about treating someone who's asymptomatic, you have to tell them, if you were going to tell them the simplest way, it would take me to treat 17 patients, asymptomatic patients, for me to get benefit of 1 patient with this treatment. So that there's that. So that, if anything, that's the one thing I want you to take away from this slide. There was interesting, there was an analysis at the end of the paper which looked at patients who had asymptomatic carotid disease on one side and carotid occlusion on the other. And they did not benefit from carotid endarterectomy if you just decided if you thought their asymptomatic disease was bad and you thought they may need an endarterectomy prophylactically. The ACST came a bit later, although the data was collected during the same time period. And again, they had all the bells and whistles of, randomized controlled trial, looking at, asymptomatic patients, either treating them to endarterectomy or best medical management. What's interesting, again, they don't really mention this, let's go through the details of the paper, or look at the supplementary material, is that not all the patients were asymptomatic in the trial. They were mainly asymptomatic. And if you look back at the numbers, 12% actually had symptoms before the actual trial started. So, there's that bias or that issue with the paper in itself. And again, look at what was published and what was reported again in the headlines. We're reducing the risk of disease by 55% or almost half, cutting the number of strokes in half. That's great. But the number needed to treat, again, 19, even larger than the previous trial. So think about these numbers as going forward as in the back of your mind in terms of whether or not to treat patients who are completely asymptomatic from this disease. And again, this is a summary slide, and this is what people go with this paper, which was a meta-analysis or combination paper. And the headline is, I've highlighted it in that red bar, we cut strokes down by half. And again, the absolute risk reduction is pretty low, and the number needed to treat is pretty high. So that was food for thought, or thought for food. But where do we go next? And let's talk about the symptomatic patients. So changing gear a little bit, and basically those 2 major trials again that looked at symptomatic patients, and you guys have probably heard of these trials before. But NASIT, again, randomized prospectively controlled study with CEA versus best medical management. Best medical management at the time would be actually a combination of things, either aspirin or anticoagulation or smoking cessation or lipid therapy. A large number of patients collected over a variety of centers, but they tried to make sure that the surgeons were capable of doing the procedure before letting them do or be enrolled in part of the study. So they stratified their patients into different levels of stenosis: severe group, moderate group, mild group, and looked at what these different stratification issues would pan out to be. And again, I try to give you a bit of a summary of each group, but really what I want you to take away from the slide, although there's a lot of data, is number needed to treat again for each of the groups. So for the mild group with less than 50% stenosis, 26% needed number 26 people needed number to treat to get a benefit from one patient. The moderate group, greater than 50%, but up to 70% stenosis almost. You need 15 patients, similar to the asymptomatic group, or asymptomatic patients in previous trials. And then really the only value you get is those patients have greater than 70% stenosis. The number needed to treat is 8. So there was, it's not a low number needed to treat, but I think that people were using that as the first set of data to really validate the use of carotid endarterectomy in patients as opposed to best medical therapy. The absolute risk reduction is slightly higher, 17% for that severe group. How does that, benefit patients in the long run? Well, they did find the significance and used the p-value to confirm that people with greater than 70% stenosis probably should get a CEA if they're symptomatic. What's interesting is tandem lesions, patients who have extracranial and intracranial stenosis may benefit from the treatment of their extracranial stenosis. And what was not surprising at the time is that elderly patients tend to do worse with this procedure, although subsequent studies, which we'll talk about, kind of refute that idea or that concept. The Europeans did the same thing, and they had their own large registry trial. And this trial was even a little bit more muddier because the data was actually collected in the 80s, and so there's a lot of differences in the way the data was provided as opposed to the American study. We'll talk about that later, especially in terms of measurements. And again, similar numbers. Number needed to treat. The middle figure there, 9, is the key number here, which I want you to take away from this as I can calculate. And you can calculate these numbers just by using a 2x2 table and using the data that is provided. The reason for some of the data differences, I'll go back one. The reason why there are some data differences between this, because if you look at that yellow bar at the bottom, the CEA did not appear to benefit patients with more than with patients less than 80% stenosis. That's different from the American study, where you could get benefit from those patients who had 70% stenosis or greater. Why is there a difference? Well, it's the way that they measured the level of stenosis on their imaging. Now, there's different ways to measure this, and it has come quite far from this kind of way of measuring carotid stenosis. But we have an angiogram, and this is the easiest way to do it, and most easy way to reproduce these kinds of measurements over different centers. To use the angiogram and basically measure the area where it's narrowest and the most appropriate distal diameter, and that's how the NASIT criteria was performed. The ACST trial was a little bit different, and they just looked at the bulb specifically, and what the imagined distance of the bulb used to be was factored into that calculation. A lot of boring numbers aside, down the road they found out that the way that the ACST trial calculated stenosis would overestimate the level of stenosis for whatever reason, and that has been shown in subsequent trials that that may have affected the data in calculating whether or not patients would benefit from a certain level of stenosis, and hence the different numbers. What's interesting now is that this is a two-dimensional image. Most measurements are two-dimensional, but we all know that the carotid artery is a tube and is a 3D structure, and plaques just don't, not all plaques act the same, not all plaques behave the same, and ultrasound has made a huge impact in whether we not, in doing the decision-making process, whether or not a patient should be treated or how they should be treated. Going as you see these patients in clinic, do they have a soft plaque, a hard plaque, calcification, ulceration, et cetera, et cetera. And then the kind of advent of carotid stenting came about, and how do we answer that question? What is better, carotid stenting versus carotid endarterectomy? People have been, since that time, cardiologists, have been wondering whether or not they're squirting heart. Should they put a stent in the carotid? And the vast majority of patients during the time that the Crest trial was accruing data around 2000, 2005, a lot of patients were being treated for asymptomatic carotid stenosis with a carotid stent. And that's one of the issues with this trial, is that midway through this trial, they decided to change this trial from a symptomatic study to include asymptomatic patients as well. And I think that was mainly because they were not accruing enough patients, and just to boost the numbers. But anyway, it ended up, the trial design ended up being a large randomized controlled trial. All the key words to suggest that it's high level of evidence and good data. The Crest primary endpoints were a composite of stroke, MI, and death, and then there were other secondary aims for this. Basically, this is what they kind of thought would be the best way to answer the question whether or not a carotid stent or a carotid endarterectomy would be the best solution to this problem. The vast majority of carotid surgery in this study were done with general anesthesia, and the vast majority of patients who were getting stented were treated with aspirin plus clopidogrel Plavix for at least 4 weeks post-procedure. But here's the actual data. So although the composite endpoint, as you can see, did not reach any level of significance even out to 4 years, if you look at stroke and MI and you separate those two, you can see that there seems to be a benefit for doing endarterectomy in patients. Well, there's some role of endarterectomy or superiority of endarterectomy over carotid stenting when considering stroke, and there's some benefit of considering carotid stenting when looking at MI. But what is an MI as defined by the study? So the vast majority of patients who had MIs in the study only had enzyme leaks. So that has been an issue which has been called into question since the study was published. What's fascinating is, and sometimes I would encourage you, if you ever see a landmark paper in the New England Journal of Medicine, there's a whole set of data in the supplemental section that's never published. And this figure I got from the supplemental section of the New England Journal of Medicine for the Crest study when it first came out. And I'm pretty sure they didn't want to publish this because it doesn't look great. Now, they have great figures in the final paper, but this actual slide gives so much more information, looking at the confidence intervals that you all know about, that if we look at just that top bar that's highlighted in red, there's clearly superiority of carotid endarterectomy over stenting for stroke and death. And those are really what we worry about. When you get a patient who has disease in the carotid, you'll worry about death and stroke going forward if they're symptomatic from this. MI was defined as an enzyme leak for the vast majority of these patients. And when they did a follow-up analysis on these patients, patients actually weren't really worried about their enzyme leak or their cardiac event post-procedure, and would rather care whether or not they had a disabling stroke. And part of that is, basically, if you think about the patients who are getting carotid artery stents, they are on aspirin and Plavix, and that may be cardioprotective anyway in the long run. So different ways to explain the data, post hoc or a posteriori, but certainly the data speaks pretty loud right there. So there's been a slew of other trials before Crest, looking at carotid artery stenting. The vast majority haven't validated the use of stenting, with the exception of maybe one. The SPACE trial, a failure to show non-inferiority compared to carotid artery stenting, carotid endarterectomy. The EVA 3S trial, I won't go into the details because it's really tedious, but I will mention this trial, the International Carotid Stenting Studies trial. Again, a large multicellular trial. Look, classic, evidence-based medicine stuff. But this figure, hard for you to see, but I hope you can kind of see that the vast majority of outcome measures were in favor of carotid endarterectomy versus carotid stenting. So again, you have all this data that's building at the same time that Crest was building and getting published. Does anyone know who this guy is? Just guess. Anyone? It could be Dave. It could be Dave with more hair. This is when he was in college. This is Thomas Bayes. Thomas Bayes was a minister in the 1800s who basically defined the first set of thinking about Bayesian analysis, or looking at a belief system when you're looking at data. So when we look at data now, we're on a frequentist basis. We look at long-run frequency. We look at statistics as a long-run thing. Well, the field burgeoned with this gentleman looking at levels of belief before you go into a statistical practice. So whereas the uncertainty in normal statistics that we learn in college is the data itself, we're not quite sure about it. With this type of statistics and this type of analysis, the observer, or the person who is looking at the data, that's where the locus of uncertainty is. So a year ago, I used Bayesian analysis to study this question, whether or not carotid endarterectomy or stenting was superior. And what I did was, if you look at that top bar, before you go into any of the thoughts, you either are a strong advocate for stenting, you don't know whether stenting is going to work, or you're a strong skeptic of stenting. You're like the Robert Harbaugh of this world. So you have you're not really for stenting at all. Now, if you were at true equipoise, look at that middle line. If you did not know whether stenting or carotid endarterectomy was beneficial, you were at true equipoise. That was your belief before this. I combined the trials in a sequential method so that what would happen after the first trial, the Sapphire trial, it was positive for stenting. So you do a fancy calculation and you discover that you've moved your belief to 60% towards stenting. Keep adding the trials as you go through the years, 6 or 7 trials later. If you're at true equipoise at the beginning, you're now only 9.3% likelihood to favor stenting based on purely on the data itself. And you just use Bayesian analysis, Bayesian calculation through each trial sequentially. And even if you're a strong advocate, if you're just like, I'm a cardiologist, I love stenting, you should, if you just went by the data, only be 30% for your belief, which should only be 30% for stenting altogether. Now, let's say you're going back to the slide. Let's say you're at 9.3%. It's been 10 years since the first trials. You're at 9.3%. What trial could they design to convince you to become a strong advocate for stenting? So I calculated the reverse effect, and if you're going to have a trial that brought you from that 9.3% to 80%, again, a strong advocate for stenting, you would need a trial that was powered for certain significance and a certain power. As I mentioned with the power calculations there, you would need 4,000 people in each trial arm, or 1,500 in each trial arm. So you can imagine the impossibility of that ever happening, even if you're a Crest 2 or Crest 3 planner. If you're purely looking at Bayesian analysis, it would be almost impossible to convince you that stenting was any better at this point in stage, unless you had a trial that big. And I did a kind of an analysis. Most meta-analysis look at each trial individually, and if you look at a bar, but if you add the numbers of patients up together, the Sapphire trial, you can see how the confidence intervals are huge. But as you add the patients and the data sequentially, that your level of confidence, or your confidence will shrink, but you tend to favor CEA over stenting, and you tend to stand on one side of unity versus the other by the time Crest comes out. So my mini conclusions are, always remember that carotid artery disease is an embolic phenomenon, rarely hemodynamic or not hemodynamic. It's hard to convince yourselves that stenting would work all the time. And based on recent randomized control data, CEA seems to be superior than CAS, but there's always a role for carotid artery stenting in patients who are ineligible for surgery, have had prior carotid artery surgery or prior radiation to the neck or any type of neck surgery that would limit your surgical capabilities to do CEA. And in the end, you have to just talk to your patient and see what they would prefer based on the risks of each procedure involved. Now, I'm going to go through each procedure if I have time. For each procedure, it's wise to get a checklist for each procedure, and just like any other flight plan, like a physician would. So for carotid artery stenting, patient has to be on aspirin. Where I was trained, the patient were on aspirin and Plavix. Yes, the carotid endarterectomy patients were on aspirin and Plavix. Should you choose regional or general anesthesia? A lot of patients, the vast majority of patients, I think, are you tell them that we're going to do general, it helps. But I was trained to do it under regional anesthesia, and I'll show you a slide on that too. Should you use EEG and what other types of monitoring? Here, what I've found, which has been great, is that we have a fantastic transcranial Doppler lab and very capable people doing that in the operating room. So they can give you real-time information about flow. They can give you real-time information about emboli if you're mucking around the carotid or developing thrombus in either carotid artery as you do the procedure. EEG, as you all know, can give you a delayed information and tends to vary with the anesthetic involved. And then other nuances, shunt or no shunt, patch or no patch. I think that's all dependent on the surgeon and how you were trained. And some surgeons just shunt the patient up front before they even declare themselves needing it. How do you do so you can all do, it's really easy. You can all do cervical plexus blocks. You don't need an anesthesiologist to do it. You just palpate the posterior border of the sternocleidomastoid muscle, and that's where the majority of the nervous plexus are coming from. And you just use 0.5% lidocaine with some epinephrine and just inject 5 to 10 cc's in 5 or 6 different spots down the posterior border of the sternocleidomastoid, and then possibly a little bit more along the incision, however you want to make the incision. And that's it. And when at Penn State, the residents did all the blocks. You didn't have to have an anesthesiologist there. You just did the block ahead of hand, and the patient was awake through the procedure. It's very easy to do. Surgical nuances. Obviously, the patient is supine. Turn the head 30 degrees. If you want to have the head of the bed up, that's also okay. Whether or not you choose a longitudinal or horizontal incision is up to you. I was trained to do a horizontal incision. That's been perfectly fine and exposes perfectly fine. Always have some kind of vascular imaging before you do surgery, so you know where the plaque is in relation to the plaque in relation to the vasculature and where the carotid artery is and where you need to be on the surface of the skin. The external jugular is often encountered first, and you cut it, bipolar it. What is the key maneuver here is to identify the anterior border of the sternocleidomastoid and dissect up and down it. I typically have just used monopolar electrocautery and just find my way up and down the anterior border of the sternocleidomastoid, and that's been satisfactory to expose really that region. But that should be your first landmark. The second thing you look for, as you dissect, is the common facial vein, which is a vein that runs anteriorly and is usually right over the ICA or common carotid bifurcation, or carotid bifurcation. So that's usually a landmark to know exactly where you are in relation to everything else, and if you're too low or too high, if you're lost. If you can't find the common facial vein, you're usually over that bifurcation region. Find it, clip it, and ligate it. What you normally encounter is a huge set of lymph nodes, and you've done carotid surgery before, and you say, what are these lumpy, bumpy things? And don't buzz them, don't cut them. They'll bleed. They bleed like stink. So just retract them laterally. Dissect on the medial border of these lymph nodes and dissect and basically retract. Once the common facial vein has been dissected, retract everything laterally. And you can do that with blunt retractors very easily. And the vein is once you've mobilized the vein, it's very easy then to get onto the carotid sheath. At this point, it varies. I like to give heparin at this point when you dissect the carotid sheath, because you need at least 5 to 10 minutes for the heparin to kind of circulate through the system. And so that's when you give it. And so it gives it time to circulate. The ansa cervicalis, it's right there over the carotid sheath, and you can divide it. It can be large, and so be careful. It's always a good landmark to use to go. If you go north, if you just follow the ansa cervicalis north, you will find the hypoglossal nerve. So, in your dissection, if you're terrified about cutting the hypoglossal nerve, before you cut the ansa cervicalis, just follow it up, and you'll find the hypoglossal nerve. The hypoglossal nerve itself has a few anatomic nuances. It's invariably accompanied by a vein, which you can bipolar. There's a artery called the artery to the sternocleidomastoid, which runs with this nerve, and the digastric muscle's pretty close to this nerve as well. So it's pretty easy to see. It's often useful to find the hypoglossal nerve so that you can release it and get more proximal on the carotid artery. The key is to get as proximal as you can on the carotid artery, because you want to get proximal to the plaque before you put your initial clamps down. So keep the dissection plane pretty much in the adventitia. People forget that the superior laryngeal nerve is really deep to this. It's deep to the vagus, and if you get too aggressive with your dissection and try to really lift out the carotid, you can damage it. Exposes distal ICA, as I mentioned, might have to mobilize the hypoglossal nerve. Rommel tourniquets are useful to have on the common carotid artery and the internal carotid artery in case you need to use a shunt. Those Rommel tourniquets act as a way of clamping down the shunt clamping down the vessel on the shunt when you get the shunt in position, and to get control proximally and distally. What is the classic pimp question, and you always know this, what is the order of clamping and unclamping of the carotid artery? I remember it as ice and de-ice. Basically, ice, internal carotid artery, external carotid artery, internal carotid artery, common carotid artery, external carotid artery, and reverse that. External carotid artery, common carotid artery, internal carotid artery, ice and de-ice, pretty straightforward. The reason we do this, there is a reason, is that if there's any crud in the common carotid artery, it will fly up as you clamp the common carotid artery into the external circulation, and vice versa. If there's anything that has any thrombus that's built up over time, it will shoot up the external carotid circulation as you come on and off with these clamps. The rest is pretty straightforward. You just use a number 11 blade to make your arteriotomy and pot scissors to continue the arteriotomy. Being careful that you have good exposure, you don't veer to either side of the carotid, which can happen and make your arteriotomy or stitching very hard to do later down the road. The key is, when you do the stitching, 1 millimeter apart, 1 millimeter travel, especially at the apex of the incision, apex of the arteriotomy, when you're at a very small, usually pretty small internal carotid artery if it's pre-distal, so you don't get stenosis from your stitching. Carotid artery stenting, another flight checklist, and I'm not sure who this guy is, but so again, aspirin and Plavix, you want to make sure that the aspirin Plavix, you need to have aspirin Plavix for patients who have stenting. That's kind of a mantra that we have. Although cardiologists have tended to veer away from checking whether or not the aspirin Plavix works. And I'll leave this up to each of you guys, whether or not you want to check whether or not the Plavix is working. None of the studies that we've ever done have actually checked it. Heparinization for the procedure, really easy. Awake versus intubated. So all of the carotid artery stents that I've done them awake, just like I would do a CEA. So you can have the patient totally awake. Very key is you have to, even if the patient's awake, you have an anesthesiologist there, you need to make sure that they have pacing pads on, because as soon as you balloon the bulb, you could stop their heart. So some anesthesiologists will give glyco or atropine ahead of time, or you can ask them to give it ahead of time before you do that inflation of the balloon. And this can all change, but the devices are all different depending on what you want to use. A 7 French sheath as guide, can change in size. Heparinize, obviously, when you have the larger catheters in with an ACT goal, you'll be checking these throughout the procedure. You want to use a guide catheter that will just stay below the carotid bulb. Make sure that you get an angiogram of the cerebral circulation before you actually do anything, because you want to know what it looks like before in case you do cause a stroke. If you do cause a stroke, and you want to see if you had any difference between the pre-angioplasty and stent imaging and post-angiostent imaging. It seems like it's easy stuff, but easy to forget. And always, you'll play around with fluoro machines. There's different ways to map your way into the cerebral circulation, road maps, overlays. But for carotid artery surgery, because there's so much movement, usually in the neck, or if the patient's awake, you want to have some natural landmarks. Use the spine. Use buttons that may be on the surface of the skin or the gown to give you an idea where the plaque is in relation to everything else. Navigating past the plaque through the microwire is pretty key. You don't have to have a huge J on the wire. You usually can just scoot by with a pretty relaxed curve, or not an aggressive curve on the microwire. And most systems now are rapid exchange systems. So in lab, try to see if any of the companies have an exchange system. It's totally different from what you use anywhere else in the brain, where you have one wire that acts as your support and access to the system and to your procedure, and you basically are moving catheters, balloons, and stents over that wire, while that wire stays in one place and does not move the monorail. Oh, now you have to use a distal embolic device, and all the major studies require that based on a few initial human studies using transcranial Doppler and looking for emboli, as well as cadaveric studies. You can catch, what's surprising, you can catch pieces within this, and you can see them under the microscope if you dare to post procedure. If they're big enough, you can actually see them with the naked eye. And during all these wires and catheter changes, again, this is a skill set that you'll develop over time, but stop looking at your hands. Right now in lab, you might be used to looking down a lot, but try and get comfortable with where your hands are going to be in relation to the screen and what's happening on the screen, because you really want to have you want to have complete control of what's going on in the head and have complete understanding what your hands are doing. So it's a skill that's not like surgery, where in surgery your hands are in the field. It's a very different kind of concept and something that you got to kind of get practice with. And then know your balloons. So you don't want the balloon to explode in the patient, and you don't want to overinflate the balloon. You want to make sure the balloon is prepped adequately, prepped appropriately, no air in the balloon, and you knowing that you'll end up doing possibly up to 3 inflations, either pre-stent or post-stent angioplasties. So know your normal inflation pressures. If you need to look at the card while you do it, do that. But you need to know your devices. And then drop your stent of choice. There's a number of stents out there. Each of them have their own specific issues, either their flexibility and the way that the stent is designed. And once you're done with the stent deployment, which is actually surprisingly the easiest part of the procedure, you have to then retrieve your distal protective device. And as I mentioned, check the intracranial angiogram. Make sure you didn't throw a plaque or a thrombus distally that you would then have to take out with a stent retriever. And hopefully these surgical videos will work. Is there a way to bar? Oops. There's a play button on the bottom of these. Hopefully if you just click it, it will work. So we're going to look at, so I try to get as much information as I could with one of these ones we did. So I apologize if there's pieces missing for this, but here's the typical stent placement procedure for carotid stenosis. And you bear with us as I did the editing here, looking at the plaque in multiple dimensions. You can see it. It's pretty clear and pretty evident where it is. Look at how the patient's moving. They're awake. I usually know where the plaque is. It's C3. Here's the wire coming past it, sped through that part. Here's the distal protection device going up. I won't mention any companies, but this is a distal protection device that we use pretty often. And once that's out, you basically secure it in place, and the delivery wire leaves. What's coming up next? And you can see that your roadmap is completely off. Here's the stent being deployed, and by the time the stent is being deployed, your roadmap is completely useless. So here again, you need to know where your anatomy is in relation to key landmarks. So here we are, and here's the post-stent image, and voila. Martha Stewart style. And it was that easy. So we can move to the next slide. Here's a video of a carotid endarterectomy, and hopefully we can do the same thing here. And I won't mention any names, but I hope one of you can tell me what's wrong with this picture as we do the procedure. So here we are, exposed the carotid, looks beautiful. Here's the superior thyroid, getting clipped. Mush clamps are very useful so they don't crush the vessel. Here are tourniquets being placed. Here's the different types of clamps. It doesn't matter what kind of clamps you use. Here are the pot scissors opening up. Here's the plaque itself. Now, it depends what you want to use. You can use a Penfield, Woodson Adson dissector, Freer elevator.
Yeah, this is surgical.
I don't know. I'm not quite sure. This is kind of low. Was this patient asymptomatic? I'm not sure. But here we are with feathering away the plaque, and I think he's using Woodson Adson retractor to do that. DeBakey's are useful in basically holding onto the plaque as you do this. And again, you have to be careful. You really want to get that intimal layer defined. You don't want to start dissecting into the adventitia, which can happen. You can be confused and start dissecting like mad and find yourself with just pieces of adventitia to sew back together in the case. So find that intimal layer before you start pulling out plaque, and then gently just lift it away and off of the circulation. He's pulling out the plaque to show everyone here. Oh, it looks bad. But hopefully that's the end of the video. Oh, and here's the arteriotomy again. So millimeter apart, millimeter spacing. You can use 5-0 or 6-0 proline. This is 6-0 proline. I tend to use 5-0 proline. And this gentleman is actually sewing from both ends. I just typically sew from one end. You can do either. This technique is where you sew from the bottom and from the top, meet in the middle, bleed back the patient, make sure that you haven't caused stenosis with your arteriotomy, and do that. Now, the one thing that is not in this video, and you won't see written anywhere, is how do you, the patient's got heparin on board now, how do you make sure they're not going to bleed like in the PACU? From the vast majority of times when patients bleed in the PACU and they have a huge neck hematoma, it's not because your arteriotomy failed. You'll know if the arteriotomy failed now. You'll know that there's leaking and you fix the leak as it goes. But the majority of those post-op hematomas that are all veins or venous or small blood vessels that you forgot to coagulate. So be very meticulous in your closure at this point, because the patient has got juiced up with aspirin, heparin at this point. Some people advocate reversing the heparin with protamine. I don't do that. Just let it wear off normally. And I will put some Surgicel on the arteriotomy line and a sheet of Fibrillar, a thin sheet of Fibrillar on the actual bed of the carotid. And that, knock on wood, is the way I was taught and hasn't led me to have any problems. So it's completely dry. Has been dry. I've never had to take back for that specific reason. So with that, I will end my talk, and if you guys have any questions.